We are very excited to be presenting this lecture to you. Just before we get started, just some general housekeeping rules, if you will. Certainly feel free to turn your camera on. We'd love to see you, but please do remain on mute for the duration of the presentation. We're going to have Dr. Betesh give us a PowerPoint presentation. Please feel free to type your questions into the chat box. We will be hosting a Q&A for about 15 minutes or so once she finishes her presentation, and we're happy to address those questions then. Certainly, if you need anything, myself and my colleague Chu Man are here. You can write to us in the chat, and we're happy to assist. And so without further ado, I'm going to introduce our speaker here. Today we have Dr. Andrea Betesh, and she is an assistant professor of medicine in the Division of Gastroenterology and Hepatology at Weill Cornell Medical Center here in New York. She practices general gastroenterology with a focus on the care of patients at high risk for gastrointestinal malignancies. She received her undergraduate degree in neurobiology from the University of Texas in Austin, and she graduated from the University of Miami Miller School of Medicine in Florida. She completed her internal medicine residency at Baylor University Medical Center in Dallas, Texas, where she also served as chief resident. She completed her gastroenterology fellowship training at NYU in 2018. And so with that, I will turn it over to Dr. Betesh.
All right, thank you so much, Amy. So, and thank you all for joining us today. Colorectal cancer screening is definitely a topic that is very important to me. And I was very excited to be invited to speak about it today. So definitely, I'll be happy to answer any questions at the end. So I'll get started. So let me advance the slides. Okay, so when we talk about colorectal cancer screening, I think it's important to just zoom out first and think about, well, what part of the body are we really talking about here? So in this diagram, you can see the esophagus connects to the stomach, which empties into the small intestine. And then the small intestine empties into the colon or large intestine. And when we are screening for colorectal cancer, we're screening this entire organ here. But we are not screening the small intestine, the stomach, or the esophagus. And so this is the part of the body that we are focused on. Just to put it into perspective, I put some statistics here. So colorectal cancer is very common. There are about 150,000 new cases of colorectal cancer diagnosed in the US every year. Approximately 2/3 of those are colon cancer and 1/3 are rectal cancer, but we generally just lump them all together as colorectal cancer. There are some nuances and differences in how they're treated, but generally the screening is the same. And over 50,000 Americans are expected to die annually from colorectal cancer. So it is a pretty significant disease burden. And you can see here at the bottom that the overall lifetime risk of developing colorectal cancer is about 4%, although it is slightly higher in men than in women. So I pulled these statistics off of the American Cancer Society website, and these are the estimates for 2020. You can see that there are over 147,000 new cases estimated for this year, with over 53,000 deaths. So it's the fourth most commonly diagnosed cancer, and it is the second leading cause of cancer deaths in the US. So this is a very important disease. And there are some risk factors that we have control over when we're talking about colorectal cancer. And when we talk about risk factors, I like to break it down into modifiable and non-modifiable risk factors. So there's certain things in life that you just can't do anything about, and those are your non-modifiable risk factors. So age is one of the big risk factors for colorectal cancer. And, you know, obviously there's nothing you can do about your age, your family history, your personal history, but there are quite a few modifiable risk factors that we do have control over, and I think it's important to mention them. So there are certain things that decrease your risk for developing colon cancer and certain things that increase the risk. And this diagram kind of breaks it down. And if you look through this in more detail, you can see that the same things that any doctor would tell you are important for your general overall health, your blood pressure, your cholesterol, diabetes, are the same types of things that are important for colon health. So eating a healthy diet that is high in fruits, vegetables, whole grains, fiber, that is considered to be protective, and avoiding things such as processed meats, refined sugars, things like that are thought to be risk factors. Maintaining a normal weight or BMI or body mass index is also thought to be protective, and being overweight or obese with a BMI of 25 or greater is thought to be a risk factor. Sedentary lifestyle is a risk factor, and having routine physical activity is protective. And then smoking cessation, so avoiding tobacco products and avoiding alcohol in excess, are both important for your colon health. And one of the main reasons why we're really giving this talk today, and something to really focus on, is the fact that even though colorectal cancer is common and it is quite lethal, it is preventable. And we have a lot of ways where we can detect it early and even prevent it from forming. And that's the bulk of what I'm going to talk about today. So how is colon cancer preventable? The reason why colon cancer is preventable really roots back to the biology of the cancer itself. So this diagram here shows that most colon cancer does not just pop out of thin air and show up as a big cancer. It typically starts off as these small colon polyps or little bumps or growths on the wall of the colon. And over time, these polyps increase in size, and as they become more and more abnormal, they can grow into small cancers. So they start off as small cancers, and then if undetected, they continue to grow, and they can become larger and then eventually spread to distant sites in the body. And so colonoscopy, which is one of our main colon cancer screening methods, it is a really wonderful method because we can detect the polyps at the precancerous stage and actually remove them from the body when they're in this stage, so they never have the opportunity to go through this sequence and grow into colon cancer. So colon cancer screening not only allows for prevention, but also we can detect colon cancer very early. And this is important because the earlier we find colorectal cancer, the easier it is to treat and potentially cure. So there are many people that get diagnosed with colon cancer and they are cured of their colon cancer. Some people are beyond the stage at which we can cure them, but we can still treat them. But the earlier we detect this, and even better if we can prevent it, the better off people are. So I'm going to now move into talking about how we screen for colon cancer, who should get screened for colon cancer, and when this needs to happen. So I like to break this down into two big categories. So we have colon visualization tests and we have stool-based tests. So the colon visualization tests are tests such as colonoscopy, flexible sigmoidoscopy, and CT colonography. So this is a specialized type of CT scan. And these are all tests that are designed to actually look at the colon and see, are there polyps growing? Is there a cancer in there? The stool-based tests are actually stool samples. You submit a stool sample and it gets analyzed in the lab for different features. And we don't actually see the lining of the colon on these tests, but we can get an idea of if there's a risk for colon cancer going on with these tests. Now, there's a lot of tests here, and we don't have time to go through every one of them in detail. So I'm going to focus on the two main tests. So colonoscopy is the main colon visualization test that we use, and the FIT is the main stool-based test. And if you guys have questions about these other tests, I can certainly answer them in the Q&A session. But these two are considered kind of our top tier tests. And so I'm going to spend the majority of the time on those. And really, Colonoscopy is thought to be the gold standard test because, as you'll see in a minute, as we get into the details of these tests, colonoscopy allows us to detect cancer early, but is also really the test that allows us to prevent colon cancer, whereas the stool-based tests are only detection tests. So let's talk about colonoscopy. So how does this procedure work? So you can see here in this diagram, there's a patient, they're lying on their side on an exam table, and these patients are under anesthesia. So they're asleep for the test, and this is for patient comfort. And the doctor inserts a scope, which is a long tube with a camera and a light, into the rectum. The scope goes all the way around the colon or the large intestine. And on a screen, we can actually see what the inside of the colon looks like. And here's a little, in the diagram, there's a small polyp. So polyps can be removed during the procedure. So right when we find them, we remove them. And so that's really the cancer prevention piece of colonoscopy. One of the downsides of this test is, in order to see the lining of the colon so clearly, we have to do a bowel preparation for colonoscopy. So in the normal state, there's a lot of stool that hangs out in the colon, which is normal, but it can really interfere with our ability to see the wall of the colon. So in order to do this test and really get the views that we need to have adequate screening, people have to do a bowel preparation. But one of the really big benefits of colonoscopy is that if it's normal, it really only has to be done once every decade, which is pretty infrequent. What about the FIT, the stool-based test that I mentioned? So this is a diagram I found actually from the UCLA website, and I liked it because it shows in detail exactly what you have to do to do the FIT. Basically, you put a paper towel in the commode, you have a bowel movement, and then this little kit, which has this green toothpick like device, you just poke the stool with the toothpick and you put it back in the container and send it to your doctor or bring it to your doctor. So this is obviously a lot easier than going through a colonoscopy because you just have a bowel movement and submit a stool sample. And this allows for early detection of colon cancer. But one thing it does not do is it does not prevent cancer formation the way that colonoscopy does. If the FIT is positive, you actually have to then proceed with a colonoscopy to figure out, well, what is making this test positive? Is there a big polyp? Is there a cancer? You have to find it. But if this test is negative, then it's just done on an annual basis. So while it's a lot easier than a colonoscopy, it's done more frequently than the colonoscopy. So who should get colorectal cancer screening? Probably a lot of you have heard of this age 50 number. You turn 50, you get your colonoscopy, and that used to be true. But actually, in the last few years, and specifically in the last month, a lot of different groups that sort of make the guidelines for cancer screening in the US have advocated an age 45 for screening. So it's always been age 45 for African Americans, but now more and more groups are endorsing age 45 for everyone. Right now, some of the insurance companies are covering this at age 45 and some aren't. You'd have to speak to your specific insurance company to find out. But we expect that within the next year or two, most, if not all of the insurance companies should update their coverage to be in line with the United States Preventative Service Task Force recommendations, which are now age 45. Now, there are certain populations where you may need to get screened even younger than age 45. And this is people who have a family history of colon cancer or a family history of certain types of colon polyps, individuals who have inflammatory bowel disease, such as Crohn's or ulcerative colitis, may need to get screened for colon cancer at a younger age. And people who have genetic syndromes, either in themselves or in their families, may need to get screened at a younger age. And if you're not sure if you meet any of these criteria, the best thing to do is to speak with your physician to find out if you need early screening or if you can wait to age 45. So digging into family history a little bit more so that you kind of know what to ask your family about. What matters the most is really the history of your first degree relatives. So your parents, siblings, brothers and sisters, your children. If any first degree relative has a history of colon cancer or a high risk polyp, we typically recommend early screening, and early generally works out to be age 40 or 10 years younger than that relative was at the time that they were diagnosed with their cancer. So let's say your mother had colorectal cancer and it was diagnosed at age 43. Then you would need your colon cancer screening at age 33. So for some people, this can be pretty young, much younger than the general population. And so it's important to ask your family. Now, some people don't want to share this with their family members. Some people are not in touch with their family or are adopted. And so if you're not sure, you don't have access to your family history, the best thing to do is to just speak with your doctor to try to figure out, what age really makes sense for you. So now I'm going to go through colonoscopy in a little bit more detail and what to expect with a colonoscopy, because I think there's a lot of mystery behind this, and kind of knowing more information makes this procedure a little bit less intimidating. So first off, I will start with saying that this is a very safe procedure. So while it is an invasive procedure and it does carry some minor potential risk, it is considered a low risk, safe procedure. And for patient comfort at Cornell and NYP, we do these procedures with anesthesia. So during the procedure, the patient is asleep, they have no pain or discomfort, and they really have no awareness that the procedure is going on. So they fall asleep before the procedure starts and they wake up after the procedure's over. So the actual procedure, most people find to be pretty easy. What people really dislike about this procedure is the bowel clean out, and I'm going to get into that in a little bit more detail. This procedure does require taking one day off work, but it's only one day. Some people have the misconception that they have to take off the day before to do the clean out or the day after, but really you only have to dedicate one day to having this procedure. And the day before and the day after, you can do your normal activities. In the past, people used to have to meet with the doctor prior to having this procedure. So it required a doctor's appointment and then the day off for the actual procedure. At Cornell, what we have now is a program called Direct Access Colonoscopy. And this is a program that allows people to schedule a colonoscopy with either just because they're of the age to have a colonoscopy, or if their primary physician refers them for a colonoscopy, they can actually schedule the test and not have to have a pre-procedure visit with the gastroenterologist, the GI doctor who's doing the procedure. Now, some people still want to meet the doctor before the day of the procedure, and that's certainly available for people who want it. But for the sake of convenience and for the goal of getting as many people screened as possible, our institution has created this direct access program. So people can book this procedure and meet their doctor on the day of the procedure, which I think is a really great thing that we do to help facilitate this and make it as easy as possible for people. So like I mentioned before, the scope is a long flexible tube with a camera and a light on the end of it, and it's passed through the rectum. It goes around the colon to the bottom part of the small intestine. We look for polyps and we remove them with tools that go through the scope. We remove them right then and there, and then any abnormal areas can be biopsied during the procedure. Now, what do you have to do the day before the procedure for a colonoscopy? So the diet is pretty limited the day before the procedure. It's a mostly liquid diet and mostly clear liquids, but you can have a very light breakfast on the morning before the procedure. And then you begin the laxative medication to cleanse the bowel the evening before the procedure. And as expected, this causes some diarrhea and possibly some mild cramping. And then you take the second half of the prescription laxative or the over-the-counter laxative, whichever laxative you're given, about 6 hours before the procedure on the day of the procedure. And this really helps to make the clean out a little bit more tolerable. So instead of having to take all of the medication in one sitting, we split it up, and most people find that this is preferable. We ask people to arrive for their procedure about an hour before the procedure start time. And what happens when you arrive at the facility is that you meet the nurse, you meet the anesthesiologist, you meet the gastroenterologist if you haven't already, you have your IV placed, you fill out some paperwork. And so it's about an hour of prep work before the procedure starts. And the procedure itself takes anywhere from 30 to 45 minutes. After the colonoscopy, most people are awake within 15 to 20 minutes of the procedure ending. So the type of anesthetic that we use for colonoscopy is very quick on and quick off. And so you wake up quite quickly after the procedure's over. And most people, after they wake up, they just feel like they had a nice nap. There's really no pain or discomfort. Some people have mild gas and bloating after they wake up from the colonoscopy. And that's just because we do put a lot of air into the colon during the procedure so that we can see the walls of the colon clearly. But most of this air passes on its own. You know, you pass gas throughout the day and the bloating and the gas goes away. You can eat regular food after the colonoscopy. So as soon as you wake up, you can resume a regular diet. And then your doctor will come in and speak to you about the findings. Typically, people stay in recovery for about an hour, and then they go home that same day. You will need someone to bring you home after your colonoscopy, because after you get anesthesia, you can't leave the facility unaccompanied. You have to have somebody with you. And then if you had polyps removed or biopsies taken, typically you're contacted within 2 weeks with the results of those biopsies, and the doctor's office will contact you and let you know what the pathology from the biopsy showed. So what do you do with the results? So if there's no polyps on the colonoscopy, like I mentioned before, you don't have to do this again for 10 years. If you do have polyps found in your colon during the colonoscopy, depending on the type of polyps, the number of polyps, and the size of the polyps, we make a recommendation based on the guidelines of when you should have your next colonoscopy. So some people can wait 7 years, 5 years, 3 years. It really just depends on what types of polyps you had, but your doctor will instruct you on this after you have your colonoscopy. So what are the risks of colonoscopy? Because obviously this is a more invasive test than having a stool sample. So overall, the risks are quite minimal. And I like to break the risk down into the anesthesia associated risks and the procedure associated risks. So anytime you get anesthesia, it can cause alterations in your heart rate, your blood pressure, your breathing, your oxygen level. But we have the anesthesiologists monitor you throughout the procedure. It's not like they give you the anesthesia and leave the room. They're watching you the whole time, giving you oxygen. So the risks associated with anesthesia are pretty rare. It's very, very rare for people to have allergic reactions or nausea and vomiting with the type of anesthetic that we use for colonoscopy, but it is possible. And then the procedure associated risk. So what is the risk of actually putting a scope into the body, taking biopsies, removing polyps? Anytime we do that, there's a small chance that we could cause bleeding or infection. And there is a very, very rare chance, less than 1 in 1,000, that we could cause a perforation or tear in the wall of the colon. We mention this just because it is a severe complication, but again, it's quite uncommon. So what GI symptoms might prompt a colonoscopy? So generally what we've been talking about today is screening. So a routine preventative exam for someone who has no symptoms. But sometimes people think that they're due for screening, but really they're having some symptoms. And sometimes the symptoms will make your doctor say, you know what, you should really consider getting a colonoscopy. And so what symptoms should you look out for that could be concerning? So the main symptom that we always tell people to look out for is blood in the stool. So blood in the stool is not normal. There should not be blood on the toilet paper or blood in the stool or blood in the toilet bowl after a bowel movement. And so if anyone is experiencing that, they should absolutely speak to their doctor about it because they may need a colonoscopy. Other things to look out for are changes in the bowel habits, either a change from constipation to diarrhea. Anything that's sort of atypical for you, out of the norm, is something to speak to your doctor about. Unintentional weight loss or new or worsening abdominal pain that doesn't go away. All of these things would be reasons to speak with your doctor and find out if you should get a colonoscopy. Now, another thing that I wanted to mention today, because obviously it's 2020 and we can't ignore this, is what about COVID? So patients are pretty nervous about COVID, as is understandable. And I wanted to kind of just review some of the things that Weill Cornell and NYP are doing to make sure that these procedures are safe despite what's going on with COVID. So we are taking many precautions, not just to protect our patients, but also to protect all of our staff and our nurses from COVID infections. And so the way that we have approached this, so in addition to a whole host of really intensive cleaning protocols, which you can read about on the website, we have a policy in place that anyone who's coming in for an elective procedure, including a colonoscopy, needs to have a COVID test 2 to 5 days prior to their procedure. And this is the nasal swab COVID test. And so we have testing sites throughout the city where people can come and get a pre-procedure COVID test. And this is something that's in place for now. Obviously, all of these policies could change as we get more information and vaccines and the like. But for now, the way that we're managing this is that all patients get a COVID test prior to their procedure. And this helps us feel really certain that all patients coming into our facility are COVID negative. And then in addition to that, all of our physicians and our staff, we all do a COVID screening questionnaire every day. And also everyone who you would ever encounter in the hospital is wearing a mask. So we have really done every precaution possible to keep our patients and our staff safe during this time so that we can continue to screen people for colon cancer, because it is so important. Now, to make an appointment, either for a colonoscopy or to see a gastroenterologist, if you have symptoms or questions, or if you're not sure if you need a colonoscopy or not, we have multiple locations throughout the city for both in-person visits and also for video visits. And we are taking new patients for video visits. It used to be that in order to do a video visit, you had to be an established patient, but now anybody can do either a video visit or an in-person visit as a new patient. And I put our phone number here so that you have it. And with that, I will stop and take any questions that anybody has.
Great. Thank you so much, Dr. Betesh. That was a wonderful presentation. And so, yes, want to open it up to any questions here. Certainly feel free to type it into the chat box, but I just have an initial question. In regards to sort of the screening age, I know typically it's 50 years old. In your professional opinion, do you see it lowering, just given any recent like the recent deaths that we've had in our society, or what is your opinion there on the age to start screening?
Yeah, so it used to be age 50 unless you were African American, age 45, and then if you had a family history or other risk factors, potentially earlier. And kind of the history of this has really evolved just in the last few years. So in 2018, the American Cancer Society came out with a study, and they recommended age 45 for everybody. Now, that was not initially adopted by all of the other societies that make the guidelines for when people should get screening. So initially, people saw that, but the GI societies, the United States Preventive Services Task Force, did not make any changes. But based on that American Cancer Society recommendation, some insurances did start covering it at age 45. And when that happened, we did see patients start coming to us at age 45 for routine screening. What happened last month, which I think is really significant and probably didn't get the media attention it deserved because of all of the other things that are going on in the media these days, is that the United States Preventive Service Task Force put out a paper saying that they recommend age 45 for everyone as well. And that recommendation is still kind of in the open comment period where members of the public can make comments on it, and then it will be finalized. And that'll probably happen in the next few months. And I think that Once that goes through, and that's expected to go through, and that 45 is expected to stick, most of the insurance companies are going to adjust their coverages. Probably all of them will, so that we have an age 45 universal screening. Now, there's one major group that still has not weighed in on the 45 versus 50 controversy, and that is a group that's made up of the gastroenterology societies in the US. They're still updating their guidelines, but it is expected that if the American Cancer Society, the US Preventive Services Task Force have endorsed 45, that the GI societies will as well. And like you mentioned, we are seeing colorectal cancer in younger and younger patients. So I didn't include these statistics, but if you track the incidence of colon cancer over time, for the age 50 age group, it's actually going down, and it is thought to be mainly because of screening. But if you look at the under age 50 group, so like the 45 to 49 group, we're seeing a rise in the incidence of colorectal cancer and predominantly rectal cancer. And it's a scary thing, and nobody's really sure why this is happening. Is it environmental factors? Is it diet? Is it obesity? No one's really sure. And there's a lot of active research, including at Cornell, that's going on in this area. But we are seeing colorectal cancer in younger people, and we do take symptoms seriously. So if someone comes to me at the age of 42 and they say, I saw some blood in my stool, 15 years ago, their doctor might have said, oh, it's probably a hemorrhoid, don't worry about it. But now, knowing the recent data, deaths of high profile people at young ages from colorectal cancer, we take that really seriously. And we do proceed with a colonoscopy for that. And yes, most of the time it's not cancer, but if 1 in 100 turns out to be colorectal cancer, it's worth it, because we do not want to see, young people getting this disease, because it is quite a terrible disease. So I do think that this screening age is going to go down over time, and I think it's a good thing.
Thank you for that. Yeah. Okay, I just want to a few more questions that came over into the chat here. So someone asks, does diverticulitis increase the risk of colon cancer? And if so, what is the frequency that you should have a colonoscopy?
So diverticulitis does not actually increase the risk of colon cancer. So having diverticulitis by itself doesn't make you more at risk for having colon cancer. But what I will say is, if you've had an episode of diverticulitis and you have not had a recent colonoscopy, your doctor will probably recommend that you get a follow-up colonoscopy. So if you've had diverticulitis and there has not been a colonoscopy within the previous 12 months, you probably should see a gastroenterologist, because sometimes colon cancer can present as diverticulitis. So while it is not a risk factor for colon cancer, it is a serious condition of the colon that could require a colonoscopy, and definitely is something that you should see a gastroenterologist for.
Thank you. And similarly, if you're having 3 melanomas and 2 basal cell carcinomas, does that increase the risk? And again, if you could speak to the frequency of doing the testing.
Yeah, so certain cancers kind of clustered together. And so in some syndromes, we will see that people can get multiple types of cancers. But melanoma and basal cell carcinoma by themselves do not increase your risk of colorectal cancer. So it wouldn't change like when you need to get colon cancer screening or how frequently you need to get it. But certainly if there is an individual who's having multiple cancers, sometimes that can be suspicious for a genetic syndrome and could require additional testing. So I think if there's a concern, okay, this individual is having a lot of different types of cancer, that's something that should be taken seriously and seen by somebody who's a specialist to determine, does additional cancer screening need to happen because of these other cancers that we're seeing?
Thank you. Another question we have here is, what is your recommendation for people over 75 years old if their previous colonoscopy results were normal? Are they still needed to do routine screening?
So that's a really good question. So if you look at the guidelines, I mean, the guidelines that start at either age 45 or age 50, typically they recommend routine screening until age 75. And then there's kind of this gray area between 75 and 85 where there's not a lot of strong data telling us should people continue to get screened or not. And this is really based on the fact that when we're doing a colonoscopy and we're removing a polyp, we're really talking about preventing cancer that's about 10 years into the future. So if you're 75 and you're healthy and doing well and you don't have a lot of other medical problems and your life expectancy is 10 years, 20 years, 25 years, then it may make sense to continue to get colon cancer screening because we're talking about preventing a disease that could occur in your lifetime. But for someone who's in their late 80s, who has a lot of other medical problems, there comes a time where the risks of the procedure start to kind of add up, and the benefits of preventing cancer about 10 years down the road starts to become less and less of a real tangible benefit. And so that's over 75 age group, it's really a very personalized decision. And the guidelines are not very strongly worded one way or the other as to stop or to continue. And it's really a personalized decision based on you, based on your overall health, based on your family history, your personal history. And there's not really a right answer, but it's kind of a shared decision-making type of conversation that we have with our patients who are over 75. But I have plenty of patients who are in their 70s who continue to get colonoscopy and colon cancer screening. And then I have some patients who say, you know, really, it's not for me anymore. And I think both are reasonable options. It just depends on the details of that individual person.
Thank you. Another question here is, has there been any studies to show certain diets will increase the chance of getting colon cancer? So for example, eating too much fried food?
So there has been some research into how diet affects the risk for colorectal cancer. We know that there are certain foods that cause a lot of inflammation and can really increase your risk for colorectal cancer. So processed meats, like smoked meats, things that are very low in fiber. Those are the kinds of things that we think are increase the risk for colorectal cancer. And a diet that is high in fiber, high in whole grains, high in fruits and vegetables is thought to be protective against the development of polyps and colon cancer. Now, that's just one factor, though. So, you could have the healthiest diet in the world, but if your family has a genetic syndrome that's increasing your risk for colorectal cancer, you still have a pretty high risk. So it's not an all or none kind of thing, but I tell people generally avoiding foods that are highly processed, high in fats and low in fiber. So those are the foods you really want to stay away from, and eating kind of a plant-based high fiber diet is the best way you can use your diet to decrease your risk.
And the next question here, and so it's asking people that have sleep apnea, and it's saying should have it done. I'm assuming a colonoscopy in a hospital setting.
So patients who have sleep apnea can still absolutely safely get a colonoscopy with anesthesia. the way we don't typically admit patients to the hospital to have a colonoscopy. So it's always done as an outpatient procedure when it's being done for colon cancer screening. We do procedures in the hospital endoscopy suite, and we also have an outpatient procedure facility. We have several throughout the city. And so for the vast majority of patients, even if you have sleep apnea, you can still have your procedure done in the outpatient procedure facility, because our anesthesiologists will monitor you, and they have different equipment that they can use for people who have sleep apnea to make sure that their breathing and their lung function is safe during the procedure. In some cases, if people have a lot of medical problems or a very complicated medical history, we will recommend for them to have the procedure in the hospital facility, just because if they're high risk to have a complication, we have the most resources in the physical hospital space. But having sleep apnea is not a reason to avoid the colonoscopy. It can definitely be done safely. And our anesthesiologists are very experienced in managing patients with sleep apnea under anesthesia.
Excellent. And our last question here is, if you happen to know, what age does insurance typically not cover a colonoscopy procedure, or is that the case?
So typically insurance will cover the screening, definitely starting at age 50. And like I mentioned, some will cover it starting at age 45. There's really not a top age where they say, no, we're not covering this anymore. So typically we don't have issues with that. The main issue right now is people who want to get screened for routine purposes under the age of 50 if their insurance plan hasn't kind of updated that coverage. And then obviously just to mention, if you're having a colonoscopy, not for screening, but for a diagnostic purpose, like you have blood in your stool, the insurances will cover that at any age, because that's thought to be a diagnostic, necessary, needed procedure, not a screening procedure that's for prevention. So generally, we don't have too many issues getting these covered, but the way that we manage this at Cornell is if a physician recommends a colonoscopy when it's scheduled, our office verifies everything with the insurance before the procedure to make sure that the coverage is all in place. Now, we can't guarantee what the out-of-pocket cost will be, because that's based on each individual plan. But if there is an issue with the insurance coverage, generally we know about it beforehand so that we can do any sort of needed prior authorizations and everything prior to the procedure happening.
I have one more question that came through, and that is, if someone finds 1 to 2 polyps in a colonoscopy, what is the likelihood that more polyps will develop?
So definitely one of the biggest risk factors for developing polyps is if you've already had polyps, so that we know that there's something about that individual that makes them predisposed to growing polyps. So definitely that is a person who we would consider higher risk than someone who'd never had polyps. And then in terms of, when they would need their next colonoscopy, if they had 1 to 2 polyps, that would depend on a couple of things. So it would depend on how big were the polyps. Were they, 3 millimeters or 3 centimeters? Because that sort of affects the risk. And it also depends on the pathology of the polyps. So there's a lot of different types of polyps. And some are higher risk than others. So if you had a colonoscopy and they told you, hey, you had 2 polyps, that's really only part of the story. You need to know, well, what was the size of my polyp? What was the type of polyp? And really all of this, the gastroenterologist will sort of help you navigate, because there are so many different scenarios that can occur. So if you're not sure, if you have a history of polyps and you're not sure when you're due for your next colonoscopy, the best thing to do is to get your records from your original colonoscopy, both the procedure report and also the pathology report, and bring it to your doctor. And then that way your doctor can look through it and determine, when you should get your next colonoscopy.
Great. Thank you so much. And so with that, I believe that we have answered all of the questions here. And so first of all, thank you so much, Dr. Betesh, for, again, the informative lecture and taking the time to answer these questions. I think it's extremely useful information. And we'll be looking forward to kind of seeing some new guidelines as they emerge here. And then also we will share your office number and locations with the audience members. So again, if you're interested in scheduling an appointment with Dr. Betesh, we'll be sure to email that to you after the lecture. And just before we leave here today, I would just want to turn it over to my colleague Chuman to give you all a bit more information on some lectures we have for the rest of the month.
Thank you, Amy, and thank you, Dr. Betesh, for such an informative, lecture. And I learned so much about, a lot of people have fear, especially for the elderly. My mom was 85, and last month she just done her colonoscopy. So it's really, it's a very safe procedure, even for someone that's past 80,
Absolutely.
So thank you. So let me just share the screen for next week. So after today, next Thursday again, we're gonna have Dr. David Scale, who is actually he's a faculty scholar for the health equity team. And he's gonna come to talk about, how to know when individual efforts at wellness are not enough, So this is a different topic, that not so much disease specific, but we welcome you all to come back to join us, and hopefully to share this with your friend too. And we talk a lot about health justice this year, and we really want to see where can we fill up the gap, to close, so make sure people can get access to healthcare, due to, maybe we talk about insurance before, right? So I know during the pandemic, many of us have not, lose their job, or, lose their medical, insurance, so a lot of people are, looking around, see what they can do. So especially now is the time, end of the year, to change maybe some of the health plan. So I hope you all can join us next week. Okay. And thank you for everyone, to spend this afternoon with us.
Thank you, everyone. Thanks again, Dr. Betesh. Have a great day.
Thank you.
Yes, I love to see all these reaction. Everybody is giving you a thumbs up, Dr. Betesh. Okay.
Great. Thank you so much.
All
Thank
right.
you.
Okay, thank you, and have a good afternoon, and have a good rest of the day. Thank you. Bye, everyone. Be safe.